Thank you for inviting me. I'm very pleased to be here at this important event, presentation of the findings of the Music and Mind study, which is an important study. You have heard that it is a very big study in comparison to other studies that have been done, and it has good results, which is also nice. And in addition, in many ways, it points to the future. But for me, it also points into my past, because it is very similar to what I did with smaller means and not as methodologically rigorous in my PhD study about 10 years ago. So what I'm going to do is I'm going to try and put this study into a larger context. Music in Mind is a good study and a big study, but it's not the first study in the field. And I'm going to reflect a little bit on the evidence to date. Music in Mind was about children. You all know the main problems of childhood. Children are small. Childhood begins when they are born. They are emotionally unstable. They don't know as much. And they don't like to eat their vegetables. There are a lot of speculations about the etiology, that is, the reasons for this disorder. Some say it's sociological, because children don't have high income. And some say it's biological, because it starts when they are born. And also twin studies show that twin siblings of children are also children. Treatment options are very controversial. Some say that schooling helps, but others say that also without schooling, after 10, 15, 18 years, this problem goes over by itself. There is something more serious behind this, and that is that we have really some specific challenges in child and adolescent mental health care. We see often, for ethical or practical reasons, that there is less research directly focused on children and adolescents than on adults. So often when we look at the evidence, we need to consider indirect evidence from adults. And also, the diagnoses are often not as clear yet. So we see that in the Music and Mind study. Behavioral or emotional problems is something that we see quite commonly, rather than one of several hundred very clearly, narrowly defined diagnoses. So there's also this issue of lumping versus splitting in research in this area. Should we be lumping age groups? Should we generalize, for example, from young adults to adolescents, or from adolescents to children, or from adults to children? And what about diagnostic groups? How allowing can we be in lumping those different diagnostic groups together? And there are some general challenges. In preparation for this talk, I read the study protocol, and I saw that some of them, study protocol for the Music and Mind study, some of those challenges are also described there. Effectiveness versus efficacy, so that is, does this treatment work in routine care? More current term for that is pragmatic trials. The Music and Mind study was a pragmatic trial. Versus efficacy, which is a study that is usually more narrow and looks at more like a laboratory setting, which makes it often easier to find effects, but harder to generalize those effects. And another challenge that has been addressed somewhat, but not very much so far, is dose-effect relation. How many sessions, how many times a week, how many sessions in total do we really need to make a difference? Probably most of you have seen this graph so many times that it's become quite boring to you, but I'm not sure about this actually. I think the researchers among you are already bored to death by this, and maybe also clinicians here, because I know that in the UK this has been very important. It has become very important with the rise of evidence-based medicine. So very briefly, there is this idea that there is some hierarchy of evidence on the top that is very thin. There are fewer studies, but those are maybe more reliable in their results. Professor Semporter said something about that at the beginning. There are a number of ways how you can do an effectiveness study or efficacy study, but if we try to be at the top here, then we have, or at the top here, then it's hard to do that study, but the study can give us more reliable results. But also there will be, when we look at all the studies that have been done, there will be fewer up here than down there. And I would say this basis there helps us to build to the top. It's not so that this is a quality judgment and these are better, or the world would be better with only those. However, if we want to generalize from studies that have been done, we also have to look at not only the strength of evidence, but also at the relevance of the evidence. So there is some, if we look at the studies and reviews that have been done, there are some that are of direct relevance because those studies have been focused directly on children and adolescents, and others that are of indirect relevance. They may be generalizable to children and adolescents, but those weren't included in the studies. This is not only a challenge in music therapy or only in psychosocial interventions, it's also a challenge in drug research. So, to try to summarize, there have been some systematic reviews, that is the thing on the top, that it means good studies, and several ones of them are summarized in a systematic way. We know something about depression, about autism, and I'm going to go into those a little bit more in a minute. So we have some evidence in these areas, and it's I've made that dot here in the middle. That means some of that evidence is directly, some is only indirectly applicable to children and adolescents. Schizophrenia occurs often in late adolescence, early adulthood, so it is somewhat relevant. However, the studies that have been done and that are summarized in another Cochrane systematic review, they did not include any adolescents. Then there are some non-randomized but controlled clinical trials by myself. This is the outcome of my PhD study, and also a meta-analysis in the same area. I will go into these ones as well. They are more general across diagnostic groups. And if we look at qualitative studies, my colleague Katrina McFerrin summarized and found more than 140 articles only in adolescents. This body of literature is much broader down here. And like I said, this is important as well. What did the studies so far find? In terms of disorder-specific evidence for autism, we know that music therapy improves social communication in autism. This Cochrane review that we have done in our team was updated this year, and the previous version is cited in the Music and Mind Study Protocol. At that time, there were 3 studies with something like 25 or so participants. Now we have a total of 10 studies and a total of 165 participants. So if you divide that, you see that the studies, each of them is quite small. On average, 16, 17 participants in each study. that reflects how hard it is in autism to recruit. But it also reflects the state of the field. And it also shows how Music in Mind was a big step forward there. Then we have other systematic reviews of mostly indirect relevance. So in depression, we have a Cochrane systematic review published a few years ago with 5 studies, and there was another bigger RCT published in the British Journal of Psychiatry 3 years ago, where I was part of. So in total, at least 6 studies have been done with around 300 participants in total. So we have a little bit more there. And one of those studies concerned adolescents, but that was an unpublished study, and it was very small. It was about a school-based intervention with music listening. We haven't addressed very much yet what kind of music therapy is done. So you have already seen and heard some examples. It could involve active music making, or it could involve music listening, or most often probably a combination of those. These Cochrane reviews or systematic reviews are very general, and that has to be so because they summarize the evidence of music therapy and not the evidence of a specific type of music therapy. Also of indirect relevance is that we know that music therapy improves symptoms and functioning in people with psychosis. That is a Cochrane review that was also updated a few years ago and included 8 RCTs with about 500 participants. That was also a big step forward from the previous version a few years before. So it's really a field where a lot of research is going on. And it's very nice to see that there are those in size and quality and number of studies, this increase that we are seeing. Music therapists are quite brave, I think, to embrace this challenge. There is also evidence from studies across mental disorders. So of direct relevance to this age group, the first thing there was that I would like to talk about, at least, was a meta-analysis that tried to summarize all the studies in CAM until 2004. We found then 11 studies, but only one of them was a randomized study that was also about adolescents. And all had small sample sizes again. If you divide the 188 in total by the 11, you see that each study was quite small. And also there, various behavioral, emotional, and developmental problems. The review found medium to large effects that were homogeneous across age and diagnostic groups. Doesn't mean there couldn't be differences, but in that review there weren't. There was no evidence of such differences. We know now that in the Music in Mind study, adolescents seem to benefit a bit more. Then we did a controlled but not randomized study. That was the biggest study that was a little bit bigger than the previous studies. Age range, again, very wide, and mental health problems also very widely defined, anything in the F category of the ICD-10 system, so any mental disorder basically. And the finding was that music therapy improves behavior problems, quality of life, and burdens on family in some of the children that depended on comorbid problems. A very interesting finding to me, also for me as a music therapist working practically, was that the use of specific music therapy techniques predicted larger effects. That was published in this second paper. What does that mean? In that study, it would today be called a pragmatic trial. I didn't have that term then, but now it would be called a pragmatic trial. We said music therapy is anything that a music therapist does. And what does a music therapist do with children? They can do a lot of things. They might be playing football or or all kinds of different games in addition, or sometimes even instead of making music. And the music therapists believed that this was as helpful, so they were asked to self-rate as well, but the parents' and children's own ratings indicated that actually those cases where specific music therapy techniques were used benefited more. In addition to these studies, so like I said, these ones were getting there in terms of sample size, but in terms of the rigor with which the study was done, they weren't quite there where we are today. In addition to those, there is also a systematic review that should be mentioned. It was about adults, but it was also across the range of mental disorders. 15 studies with 700 participants, and it highlighted in the meta-regression the importance of the number of sessions. It actually provided some formulas that could be used with some caveats, but still to predict how many sessions do you need to get a good enough effect. I think the Music in Mind study had 12 sessions, 12 weeks, one session a week. So it could be that with more sessions, the effects would have been bigger. Probably, if I had been on the board at the beginning, I probably would have recommended twice a week, but we could discuss that, of course. All of this is very preliminary, I think, and it's even more impressive that you found some good results, even with only 12 sessions. Yes. For example, in this depression study, they wanted to have weekly sessions. I told them do twice a week, and they did it, and it worked well. But it could also work well with once a week. One question that I've mentioned before, and that I think stays with us. So it's just come back now with this study. Should we be lumping or splitting? And I don't know what the correct answer is, what the best answer is to that. I think for lumping, for combining different mental disorders or not thinking too much about diagnosis, speaks this phenomenon that is sometimes referred to as communicative musicality. Music works similarly for everyone. We learn first music, then language, and even as adults, when we use language, the musical qualities of the language are very important, often more important than the words that we use. So we could say we practice to communicate through music. That is something that is true regardless of how old we are or what disorder we have. And there is a lot of research to support this, basic research, infant research, that I guess many of you are familiar with. Music therapists have used this research quite a lot. So both on an individual level and in our development, we probably can say that music in some ways precedes language. And also communicative and social skills, which we can address through music, are relevant to all mental health problems. But for splitting speaks that mental disorders differ in the degree of problems in those skills. There are also other problems that have nothing to do with that, and they also differ in the persistence of those problems. Also for splitting speaks that the healthcare system is set up in that way. Not always. I mean, there are these general mental health services, but the question that we get from policy providers is often, yes, but for which diagnosis, for what disorder really exactly does this work? And evidence-based medicine has developed in this direction as well. Specific treatments for specific problems. There is a lot of other literature to say that the treatments are not always as specific. I only want to mention the common factors research in psychotherapy. So not only in music therapy, but also in verbal psychotherapy, a lot of people think that it is not really true that the treatments are so specific. There are a lot of commonalities. A lot of things have to do with us as humans and not with our problems only. So I am very sympathetic to the approach that the Music in Mind study has taken, but I also see that there are a lot of demands from outside that say you have to be specific, what is the problem? And this idea of defining the PICO, the population intervention comparison outcome, is often used in a way that says the population is clearly defined in the Music in Mind study, and it was clearly defined in my PhD study and in those systematic reviews that I have summarized. But some people think population definition equals diagnosis. There are some ongoing studies as well. The Time A study is a multi-center trial of improvisational music therapy for children with autism. These children are younger than in the Music in Mind study, 4 to 7 years of age. We are coordinating that study in our research group, and we have an international group of I think 9 countries at the moment. So it's very exciting to do this. Some people are involved in both, in the Music in Mind and in the Time A study. What was very interesting about that study, apart from these usual challenges of getting recruitment, large scale, and so, is that it actually required us to achieve a consensus across countries. In Music in Mind, there was one therapist. It's still so that with each new client this will be different, but you have less variability there. In the Finnish depression study that I mentioned before, there was a handful of therapists, but all trained at the same place and all practicing in the same center. That is a bit more challenging, but still easier to get some consistency. But when you have therapists who are trained in Brazil, Korea, Australia, USA, Norway, Austria, then it really becomes a challenge in itself to find that common language. And that is also it has been for me one of the most exciting and rewarding parts of that study. In addition, that study is also looking more closely at dose-effect relations. So some of the children are receiving 1 session a week and others 3 sessions a week. Yeah. Then there is the HUMS trial. HUMS stands for healthy and unhealthy use of music. That is an interesting study that is now carried out in Australia, and I'm part of it as an advisor. It's interesting because this is one of the first prevention studies. It is about preventing mental health problems by looking at people who tend to have uses of music that might be unhealthy for them. So it could indicate some emerging mental health problems, the way that they are using music, so we screen adolescents in schools and then we give a school-based group music therapy intervention and try to see if that can help to prevent depression or other mental health problems. The Music in Mind study I don't have to tell you anything about because you have heard about it already. If I look at this body of literature as a whole, I would say that there is a trend towards pragmatic trials, and that is very welcomed because we need those studies that really say something about how music therapy is practiced in the field, and that has been really a big change since the time when I started looking at research 15 years ago. At that time, I was very unhappy with the music therapy research literature because it had nothing to do with the way I work. And this has a lot to do with the way that we work in music therapy now, so I'm very happy about this trend. However, it is also necessary, it will remain necessary also to look at mechanisms of change in the future, and this is tricky. If it's hard to prove that music therapy works, it's even harder to prove how it works. It's not so that nobody has tried, but as you know, there has been a lot of qualitative research, some observational studies. With that I mean studies that could be quantitative but not necessarily randomized. And neuroscience, there are some studies there, but I think the connection to music therapy practice and music therapy way of thinking is still not good enough, so there's a long way to go there in understanding how music therapy works. And so, in conclusions, I think I can say that in building an evidence base in music therapy in child and adolescent mental health care, it's very good to see this trend that large or larger studies continue to emerge. I don't know where we will be in 10 years or 15 years, but those of you who are involved in medical research know that 200 participants in one study is not the end. There are studies that have several thousand participants. I don't know if we will get there in music therapy, but the sky is the limit, so to speak. And I would say that both the approaches of lumping and splitting can be appropriate. We need those very tiny spotlight type of studies, and we need those broader studies, both of them. And in terms of practicing music therapy, both the classical models of music therapy are and continue to be an interesting subject for research, and also new approaches, new ways of doing music therapy, for example, in preventing, and also involving the context, involving the families, for example, especially. This type of research isn't easy to do, and so I want to close with a song that many thanks to Amelia Oldfield, who was involved in both the Music in Mind and the Time A study, and that says this very nicely about the challenges of doing trials in this field. Thank you.